Hi, everyone. Good morning, good afternoon, or good evening, depending where you're exactly located on the globe or when you are actually watching this webinar. So my name is Helena, and I'm the education lead of the IPT-HOPE, and I would like to thank you all for joining us today for the lymphedema SIG webinar. The name of this webinar is Lymphology, Innovations and Challenges in 2025. This webinar is a collaborative effort between the IPT-HOPE and the World Physiotherapy European Region Cancer Group. We are very glad to bring our communities together for this important topic, and we want to highlight both current advances, the ongoing challenges in the field of lymphology. We would like to introduce our speaker for today, which is Dr. Nele Adriaenssens, who is an associate professor in rehabilitation science and physiotherapy at Vrije University Brussels in Belgium. Her work focuses on lymphology and exercise oncology, and she leads the research within the rehabilitation research group at VUB. She teaches widely lymphology and oncology rehabilitation and has an impressive international record of publications and collaborations. We are very pleased to have her here with us today. Nele also serves as the lead member of the World Physiotherapy European Region Cancer Group. She's also the lead of the IPT-HOPE Lymphedema Special Interest Group, and she will talk about that later today. And that's the link between those two groups for today's webinar. We are very pleased to have her here today. The floor is yours, Nele.
Thank you so much, Helena, for the very kind introduction, and thank you also for being here. Also, from my part, I want to welcome everybody. If indeed you're in the morning, afternoon, or evening, I'm very happy to be here as well. Thank you very much. So indeed, we are going to talk about lymphology today, so I'm very excited. And I want to talk about innovations and challenges in this year and in the next years. But first of all, I also prepared a small introduction, as Helena was explaining. We have a special interest group within the IPT-HOPE about lymphedema that I'm very excited about and very happy and honored that I can work with my colleagues, which I also wanted to present to you today. That's Sofia Jordaio from Portugal and Elizabeth Campioni from USA. They are the SIG research facilitator and the educational facilitator in the group. And so I also want to thank them for collaborating on this webinar. You can also see our mission from our group. Of course, we want to advance knowledge, research, and practice in the field of management through the collaboration, education, and advocacy. And of course, this webinar is one of the things, of the objectives that we are doing today and that are according with our objectives as better. So some of the work that we already did 2 years ago, we also organized a webinar, but that was more basically on the physical treatment of lymphedema in general. But in the meantime, we also had a previous collaboration with the Europe region within World Physiotherapy on making this infographic that you can see at the right-hand side. So we also are providing resources for colleagues, but also for patients. And that's one of the things that we have been doing in the last years. So the work that we are currently doing, and it's still ongoing actually, because we are in the latest stage of submitting this research in a publication. But we already presented it a few months ago in Tokyo, in Japan. There was a clinical seminar that we organized on the state of availability of lymphedema physiotherapy services worldwide. And so you can also find the more extensive the recording that they made actually during this World Physiotherapy group. And I'm very happy to see that Caroline Speck-Snyder is also here today joining us, because she was also part of this clinical seminar. And so together with our colleague from Kinshasa in Africa and also in Japan, our colleagues collaborated on this to make this really a clinical seminar that was globally represented. I also want to take the opportunity today to invite you, if you have interest in joining our group, so because we are recruiting members for our special interest group in lymphedema, that you can scan this QR code and complete the survey. It's really small. It will take you only 5 minutes, but so scan the QR code and you can indicate all the questions, fill all the questions, and then we have your information and we can stay in touch to give you more information and to proceed with our Seek Lymphedema with you as a member. We will be very happy to welcome you. But so then we can go to the core business actually of today, which is, of course, the challenges and the innovations. And first of all, I made a small summary of the clinical seminar that we did in Japan, because it's the work that we have been currently doing. And it's one of the main challenges that we are facing today worldwide. And since this is an international gathering here, I also wanted to give you a quick insight into the information that we have gathered from the survey. But as I was explaining, we want to submit it by the end of the year. And so hopefully by the beginning of next year, you can find the full publication or you can watch the recording that they made during the conference. So first of all, just because we are with a very diverse public here, that there are no differences in the definition of lymphedema, I copied the definition from the International Society of Lymphology. And so when we talk about lymphedema today, and it will be mainly focused, of course, on cancer-related lymphedema, we are talking about a high protein concentration caused by a decreased capacity of the lymphatic transport, and that's mainly due to the cancer itself and the cancer treatments, and also an insufficient proteolytic action. So a few years ago, and that's really a milestone within our domain, the WHO Health Organization, they included it in the International Classification of Diseases, and so this is a very big step forward that it is inside this classification as a disease and no a disease at itself and no longer as a symptom of other diseases. So I think this is already very important information that we have from only a few years ago. Just to have a small estimate, globally, we have over 140 to 200 million of people living with lymphedema. Lymphatic filariasis is worldwide the highest cause of lymphedema, affecting over 15 million people, but also poroconiosis, which affects over 4 million people. Today, of course, we are mostly interested in the cancer-related lymphedema. And as you can see here, the incidences or the prevalence rates are very high. For the people with breast cancer, for example, 2 to 74% of them, depending, of course, on the treatment and the risk factors and so on, they develop lymphedema. But also in the group of gynecological cancers and the highest group, head and neck cancers, they develop a high amount of them develop lymphedema. So these numbers are very important, and that's why, of course, we want to dig in more into this topic, because we need treatment for those people. The current situation, and we're focusing on physiotherapy and more specifically the complex decongestive therapy, we know that it depends on multiple factors. So in the consensus document of the International Society of Lymphology, there is very well defined the two phases that we need for decongestants and maintenance, all the different pillars. But of course, this is very nice and the ideal situation. But of course, we live in a diverse world, and so it's not always possible to give this to the patient. What we see is that therapist training, for example, is very diverse in our world, but also the country's resources, also the prevalence of lymphedema, and so on. So physiotherapy education doesn't mean that we also have physiotherapy practice worldwide. And therefore, the aim of our work was to see, first of all, to map the current availability, but also accessibility and the management of physiotherapy in lymphedema care globally. We also wanted to identify gaps and needs in the field, and especially unmet needs, of course, but also to formulate recommendations for the future improvements in lymphedema care. And that's something that we want to focus as the special interest group on, these further recommendations for research, but also education, also together with Helena, we want to improve this education as well. The methodology that we have been using. So as I was explaining, we made an online survey instrument developed by our SIG and the SIG members. So we created a QR code, and then we divided the survey to the 127 member organizations of World Physiotherapy. We did this between July and September 2023, but afterwards we had several follow-up or reminders to the member organizations that didn't answer yet. The domains that are included in the survey are the clinical services for lymphedema patients, but also the education and skills of the physiotherapist. And so the questionnaires were reviewed several times, like a small Delphi study actually on its own by the experts of the SIG lymphedema. And in the end, we ended up with 28 questions, most of them multiple choice, but we also left open boxes for open-ended questions. As a result, so we forwarded the survey to the 127 member organization, and we had 60 member organizations that answered, but there were also duplicates from different countries. And so in total, we had 71 answers. But for some analysis, we included the duplicates, and for some, we didn't. But you will see this in the next slide. Here you can see the spreading of the results and the countries that have participated in the survey. You can see that Europe was the highest represented, but also Asia and Africa had very high numbers of participation. We cannot go into all the details of all those 28 questions, unfortunately, today with regards to time, but I made a small summary of important results that we found and also included them a little bit for the discussion. So we only had three countries that had no service provision whatsoever. So Guyana, Nigeria, and Rwanda, there were no lymphedema services. What we saw that it was especially in low and middle income countries that the access was limited, and also there was a underrepresentation in research from these countries. We also think that this might be due to the fact that there are different causes of lymphedema in those countries, but also, of course, because of the resources in these countries. What also played a big role in the results is that the self-referral is different between countries around the world. So some have direct access to physiotherapy, and that is a benefit. And we see that when there is direct access, that the patients are having less barriers to go to the physiotherapist. But so we wanted to ask or collaborate with World Physiotherapy to have more advocacy for direct access to physiotherapy, and especially, of course, also those lymphedema services. We also need to work on the public awareness of lymphedema, because we see that there is an underestimation of the severity, and sometimes there's even social isolation of the patients. When we look at the delivery of the physiotherapy services, we say that it's commonly through public or private services, and we only in very high income countries, we see that there is also funded services or services as part of research programs. But of course, that's not something that is very sustainable, but it is a benefit for the patients at that time point. We also saw the benefits of group therapy, so we also want to advocate for more group therapy. What we see in the physiotherapeutic management of lymphedema patients is that most commonly there was early intervention, which is of course very good. So it means that the first session of physiotherapy was in the first year after diagnosis. And in Europe and other very high income countries around the world, we see that it's also included in palliative care. So patients with palliative needs who also have lymphedema, it's only in a few countries in the world, and also an overrepresentation in Europe. When we look at assessment tools in physiotherapy, we see that bioimpedance is very commonly used, but also volumetric measurements and validated questionnaires. So this is a good thing, but there is a lack of physiotherapy-led assessments in low-income countries. So that's also something we need to work on. Skin care, which is part of the complete decongestive therapy, is also very important, of course, and especially to avoid infections, because that's a high risk factors. That was a little debated in the results. We didn't see it that often, but that's due to the fact that in some countries, it's not the role of the physiotherapist, but rather the role of the nurse or another caretaker of the team. When we looked at barriers to establishing services, we saw that there was a lack of knowledge or understanding of the role of the physiotherapist in lymphedema care, but also a lack of awareness or acknowledgement of the diagnosis and the treatment of lymphedema. So those are barriers that we really need to work on, and I think it's possible to increase this. When we look at treatment resources, that's also a barrier, of course, especially in low income countries, and it has an impact on the access to care, but also other various services. And then the second part of the survey was about the education and continuous professional development. So we saw that there was an underrepresentation of the domain of lymphology in current education. But after graduating, we also saw that there was insufficient opportunities for this continuous professional development. So there is a high need for workshops, conferences, seminars, also webinars like these, for example, and also supervised clinical placements to have more practical skills. We also want to recommend to have more postgraduate modules and more lymphology in the master level programs. Then when we asked physiotherapists about their skills, we had a medium rating scale of 7 out of 10, but there was a high difference between the high income or the very high income countries and the low countries, because it was 8 out of 10 for the high income or very high income countries, but it was only 4.5 to 5 or 5.5 for the lower or middle income countries. So that's something that we saw was a big difference. And it's very interesting to know this, because then we need to give extra efforts for those ones. When the practitioners looked at their own skills, they had a concern about the insufficient perceived knowledge about lymphology. So that's an extra recommendation for more education. And also when they looked at when patients valued their skills, they also had the impression that they had the impression that there were insufficient practice or skills for the physiotherapist. So that's something we need to take into account. Of course, every study has, or every project has its strengths and limitations. And I think the survey that we did was very good, because it was practice oriented, but also it was a worldwide targeting of the population with multiple international experts. And it was the first worldwide study to do this project on availability, accessibility, and the management of lymphedema care with focus on physiotherapy. One of the limitations is that we only explained a few terms in the survey. And so due to the language barrier, there might have been maybe some misunderstandings or not a well understanding. And therefore, maybe the answer was a little bit biased. But also the structure and the arrangement of the survey might have been different to, for example, for cultural adaptations. We didn't take that into account in this round. And also the group analysis excluded the MOs, the member organizations with multiple respondents. And so this might also affect the results. But so to come to a conclusion and to focus a little more on these recommendations, for research, we want to increase the participation, especially for lower or middle income countries, because there is an underrepresentation. We also want to conduct more qualitative research, so not only on the effectivity of the different modalities of the CPT, for example, and we also want to develop comprehensive resource guidelines. There is an organization worldwide called the Learn Initiative, but I will get more into it in a few slides. And they are also working with centers of excellence. And so in the hospital where I work, we have a center of excellence for surgery, but actually it's an interdisciplinary clinic. And so we are very happy that we have this interdisciplinary collaboration, because we also want to promote holistic care. We know that as a physiotherapist or another profession, we cannot treat lymphedema by our own. We need this team of collaboration. We also want to, within this holistic care, more monitoring and evaluation of the services. And so that's something that we want to continue in the future. When we look at education and skills, I think from the results, you also saw that it's very important to expand the education and the training, to establish continuous professional development initiatives, and to leverage the international network and collaborations. And so therefore, I also want to take the opportunity to announce or the launch of the Global Oncology course, which is organized by IPT-HOPE, and Helena is very much involved in this organization. But we also included partly lymphedema within this course, because of course it's a very debilitating and as we have seen, a very high prevalence of lymphedema within the cancer population. And so I want to thank you again, Helena, for taking this initiative and doing all this great work, because it will improve also a lot of things for the lymphedema population. When we look at the broader perspective of the society, I also want to focus on policy advocacy. I think it's very important that we have more resources to do this, also, for example, for reimbursement. And we also want to enhance awareness campaigns. And then I come back to the Learn initiative that I was talking about earlier. It's the Lymphatic Education and Research Network, and it comes from, or it's based in the US, but now they have spread worldwide. And so it's an international initiative that also has a resource center. So when you go to this website, you will see the mission, of course, as well, but you will also have access to a resource center where you can find a lot of educational material for practitioners as well as for patients. And so I really want to recommend you as a practitioner to also have a look at this website, because it's very it's very good evidence-based materials, also in different languages. And I think they are really setting an example for the world on this topic. Okay, so let's go on with the innovations part. So I focused on the International Society of Lymphology because they have an international consensus document. And so the last one was published, or the last update was published in 2023. But last month, we were all together in Turkey, which was a very nice place, by the way. And it was a conference that is organized 2 yearly. And so last month, the consensus document was discussed again. And so there were a few updates or adaptations. And every year they make a new document, but it's not published yet because we only had the meeting last month. But it's a very good document for you as a practitioner to follow up on, because they always give the latest updates on things that are happening or changing within our domain. They also have a website, so you can always find the consensus document, of course, through PubMed and so on, but you can also find it openly accessed through their website. So that's something I wanted to announce first. And then we can go into more in depth into the topics that I have seen during this World Congress of Lymphology. And you can see that there were many, many topics. And unfortunately, also due to time restrictions today, I had to choose some of them. I chose the ones that we as a physiotherapist are maybe most involved in, but of course, all the other topics, you can also find the abstract book online. It's freely available for everyone. So you can find all the abstracts of the presentations that we're giving during this conference online. And I think this is really a very good initiative from the International Society of Lymphology, because you also have the contact details. So if you find an abstract that is interesting to you, you can contact the speaker and or the author, and so maybe you can get in touch with them and have more information on this. But so I chose three topics for you, of course, on the complete decongestive therapy, which is our main focus as a physiotherapist, but also on lymphatic surgery, because there is a lot going on in this domain. It's very innovative. It has always been. But for us as a physiotherapy, we also have a role simultaneously with the lymphatic surgery. And as the last one, because I think everybody is confronted with this, the digital evaluations, but also, for example, artificial intelligence is also in the domain of lymphology. And so I was very surprised to see this, and that's why I also chose this topic. But let's start first with the complete decongestive therapy, which is, of course, very important to us as a physiotherapist. And so there was a complete session on this topic for prevention. And of course, we have known a lot, and last webinar we discussed the evidence base on the treatment. But now I wanted to focus more on the prevention and more specifically risk factors and exercise, because few years or maybe even decades ago, those patients were recommended not to use the, for example, affected arm, edematous arm, or the legs, and so on. But so I'm very happy to see that today exercise is an integral part of the CDT. And so it's even in the prevention a very important aspect of the treatment. So that's why I chose this topic. But also on the risk reduction, there are also some things that I was very surprised about, but I will show you in a minute. When we focus on risk factors, you might know that there are patient-related risk factors, but also treatment-related risk factors. And today we will focus on the patient-related risk factors, personally, but also environmentally. And when we see this slide, it's a slide that I used maybe 10 years ago in my classes that I teach at the university in Brussels. And so there were risk factors that we needed to avoid with the patients with lymphedema. And so it was about nutrition, for example, alcohol, because it might dilate the vessel wall, giving capillary leakage not the onset, but also the progression of lymphedema might be harmed by this. Then they also told the patients to avoid high temperatures, hot climate, but also sauna, use of sauna, and so on. They could not go into an airplane, for example. They could not do physical activity. For example, if you have a breast cancer-related lymphedema, they advised those patients not to use their arm at all, which was, of course, very difficult. And now we see that it's even harmful. Then there is also the mechanical obstruction by clothing of jewelry. So if you have, for example, a watch or socks that are too tight, they might obstruct the lymphatic flow, but that stays in the recommendations. Skin damage, that's also a very important one that stays in the recommendations. So they always have to disinfect when they have a wound, for example, but also a fever might be harmful for those patients and so on, because of course our lymphatic system is also part of our immune system. And so when the immune system is compromised and you have a wound, the infection, the chance that you develop an infection will be much higher. And then, of course, there are so many factors, environmental factors, that we don't even know yet if they might have an impact. And that's why I put the question mark. And maybe for now, everything that is going on with the climate change and so on, there might be maybe even be a risk factor in that as well. There was a lady, and you saw it in the program in the previous slide, that is called Cheryl Brunel, and she's doing very important work. She's also a very nice lady, but that's something else. And I'm very happy that I met her because she did a very important research, and it was also published lately. And you can see here the summary of this very big research that they did. And you can see in the left column, and now I have to look at my other bigger screen because the text is getting really small. I hope for you it's readable, but I will guide you through it. So at the left side, you can see the patients that are at risk for developing breast cancer-related lymphedema. And at the right side, you can see the patients who already have developed a breast cancer-related lymphedema. And so in the past, we didn't even make the difference between those two groups. We said it's a breast cancer patients. And so if they have lymphedema or not, we have these precautions that these patients need to take. But so now we finally have the division between the patients at risk and the patients with lymphedema. And so you can see that there is a big difference in the evidence-based recommendations for risk reduction for those patients. And I pointed out the ones that are maybe of most importance to us. And then when we look at the patient factors, we see that patients at risk with a BMI higher than 25 at the breast cancer diagnosis, they are already at risk of developing for the onset of the lymphedema. But in the right column, the patients that already have a lymphedema, there the risk factor is a BMI higher than 30. So there is a difference between the both of them. What we can also see is concerning exercise, but I will come to that in a minute in a separate with a separate study. And then there are very important things that they noticed for blood pressure and blood draws and injections. So they always told patients with breast cancer, never get anything done with your affected arm. So no blood pressure measurements, no blood draws, no injections. But there was always a problem, for example, for bilateral breast cancer patients. And so now we finally have the proof or the evidence to see that patients at risk, that there is absolutely no, it has not been shown that it might trigger the onset of breast cancer related lymphedema when you have this blood pressure taken or these blood draws or injections or whatsoever. So I think this is very important for the patients that we know this, because sometimes we also might scare the patients by telling them all these recommendations, especially when they are not true or when they are not proven. On the other hand, the patients who already have the lymphedema, they still recommend to avoid it. So to avoid the blood pressure taken at this arm, but also the blood draws and so on. So this is a very important difference. Another big difference is the air travel. So the patients who are at risk, the air travel has not been associated with an increase of developing breast cancer related lymphedema, but they can always wear the compression garment if they prefer to, but it's not proven that it works better. While on the other hand, the patients who already have the lymphedema, there is no evidence that the lymphedema progresses with air travel, but they are also recommended to wear the garment. For the temperature, the hot climate does not appear to be of increased risk for the onset of lymphedema, but for the patients with breast cancer-related lymphedema, it might slightly increase the swelling. So that's also an important difference. And both groups, they need to avoid saunas. That's something that we need to be very clear on. So I think those were the most important differences that I found, but you have the table at your disposal, so you will still find some slight differences, but those were the most important one. I also put a circle around the exercise part, and that's because there was also an interesting publication from Sandy Hayes. It's already from 2022, but they are still doing some sub-analysis on the study, and so I thought it was still very relevant for us as a physiotherapist to take it along, also because it was in this table of Brunel. What we can see here is the meta-analysis that they did on the effect of exercise on the prevention. So again, prevention of lymphedema in cancer patients, not only breast cancer patients in general. And so what we can see is that the summary, so that's what we do with meta-analysis, the summary was in favor of the exercise group. So these results in the box, it means that the risk ratio of 0.71, it means that when you're doing exercise, when you have cancer and not yet developed the lymphedema, is that you have 29% less chance of developing lymphedema when you're doing exercise. And this is a very, very important topic, because in the previous years, but still in many countries, and I still think many practitioners are still telling the patients they need to avoid exercise when they are at risk of developing lymphedema. So this is a very important one. Another important one, also still in the preventive phase, is that we can see here, but split up for the different subgroups, the mode of exercise, but also the length of the intervention and so on. But you can see that all the boxes are at the left side of the dotted line. And this means, again, that there is a positive effect in favor of the exercise on the prevention of lymphedema, even when you split it up in all these groups. So then you have more information about these subgroups. When we look at patients who already have developed lymphedema and we look at the impact of exercise for the change of volume, so the change in swelling, we can see that there is also a positive effect in the reduction of the swelling when the patients are doing exercise. So with this evidence, we can say that patients with lymphedema or at risk of lymphedema, when they are doing exercise, both are beneficial for the patient, for the volume change and not for the onset of the lymphedema. Of course, it's not only the volume change or the swelling that is important, but many other symptoms as well. And so they also did a sub-analysis on the changes in lymphedema associated symptoms, and also, for example, the quality of life. And when we look at the impact of exercise on all these different symptoms, I put a box around the most important effects that can be accomplished by exercise. And you can see that this is pain, quality of life, but also the strength and fatigue. And those, I think, are four very important symptoms that we see a lot in our patients, that we get a lot of referrals for. And so I think this is also a very good sub-analysis that they did to see where they have the impact. But again, you can see all the black boxes are at the right side of the dotted line. So they are all improving with exercise, all these symptoms. So I think, and I hope that I could convince you with this evidence that exercise is really necessary for our patients with cancer-related or at risk of cancer-related lymphedema. Okay, that's for the things that were most important for me on the complete decongestive therapy. Then let's have a look at the innovations in the lymphatic surgery. So there was a satellite symposium throughout the conference, and it grabbed my attention because there was something that I didn't know yet. There was the BioBridge collagen matrix, a novel surgical scaffold for lymphedema repair. And so I was very curious when I saw this title. And so I went to this symposium. And then afterwards, because it was really difficult for me as a physiotherapist to follow all these, actually it's an engineering strategy. So I digged into the literature and I found these two very remarkable publications in relation to this topic. As you will know or might not yet know, for several decades, lymphatic surgery is really an extra value for patients with lymphedema. If we cannot cure them with a CDT, there is still an option for some patients who are within the criteria that can have lymphatic surgery. And lymphatic surgery can be a lympholiposuction. This is especially for patients who are already in a later stage where they cannot restore the lymphatic function anymore because they have already like fibrosis or the lymphedema has already developed towards fat, for example, adipose tissue. And then we can no longer help these patients. So this is a very good option for the lympholiposuction. Then you also have the vascularized lymph node transfer. So this means that at one site in the body, they can harvest healthy lymph nodes and they can transplant it to another location in the body to restore the lymphatic circulation and the lymphatic function within this harmed area. And you can see this in the middle part of the slide. And at the right side, you can see an example of lymphovenous anastomosis, or a bypass between the lymphatic vessel and the venous system, so that the lymphedema does not have to cross the whole body in the lymphatic system to come in the end to the blood circulation. they make a direct connection between the lymphatic vessel and the venous system. So these are already very developed, and they use it in many countries around the world. But now there is something new called the BioBridge Collagen Matrix from Friba Align, and I'm not making any commercial recommendations because as a physiotherapist, we are absolutely not involved within those things. But I will not, I will spare you the details on the engineering and the technical part. But what you need to know is that it's like a small wire and it's implanted surgically during, for example, these lymph node transplant or the anastomosis that they make. And it is to guide the lymphatic vessel regeneration and restore the lymphatic function. And so I thought this was very innovative and very curious. So I wanted to find out how it really works. So it's a biological roadmap for lymph vessels to grow along, and it's biocompatible but also biodegradable. This means that the body recognizes it as natural, but it also safely dissolves as a new vessel forms. And it can be applied in minimally invasive surgery alongside the traditional lymphedema procedures that I just explained to you. But what is the clinical status? Because they were pointing out the good benefits of this technique, but I wanted to know if they have already been doing some studies, clinical studies with patients. So yeah, of course, there are some remarks. It's CE mark approved. It's also in the FDA cleared. But there are some clinical trials on the way. And in Europe, there is a prevention trial with 40 breast cancer patients with an axillary lymph node dissection where they used it, but we do not have the results yet. It's still ongoing. But so I will do the follow-up for this because I think it's very interesting. And in general, they already have over 60 surgical cases reported globally with demonstrated safety and efficacy. So this means that I think that they already have some very good results with this technique. And so we need to follow up on this also as a physiotherapist because we want to understand and to know how this is really going. The methods that they have been using in the study of Bay et al. That I presented at the first slide was a retrospective imaging study, and it's the latest one. It was published only in September 2025, so 2 months ago. And the patients underwent the BioBridge, so the wire, together with the surgical procedure. And after a year or more, they performed an MRI lymphangiography. So what they found was that there were effectively new lymphatic collectors that were visualized on the MRI. The vessel connectivity improved, and there was also a clinical correlation between this regeneration and the decreased lymph volume. And it also implies the new vessels are functionally effective and not just structurally present. So you could see it on the MRI, but you could also see that fluid was going through it. So the BioBridge actually stimulates the lymphangiogenesis. It's not just a passive scaffold, it actually actively guides and enhances the tissue regeneration, and the regenerated vessels are structurally and functionally normal. And that's what they could see on the MRI. But what, as a physiotherapist, we need to know? We have an advocacy role in this, not only for this BioBridge technique, but also for the lymphatic surgery in general. We need to refer the patients when we see that our CDT is not working for these patients. And we give the patients mainly between 6 and 12 months. If our techniques do not work, we need to refer them. And when you refer these patients, it's not that you lose them or that the or that the surgeon will not give this patient back to you. It's really a collaboration. We also need to educate the patient and also set realistic timelines. The results may take over 1 year, 1 year and a half, but the CDT, you will always have to continue it. Even before and after the surgery, they will still need you as a physiotherapist, but we need to collaborate. Some important caveats as well. it's still under development, so it's not yet the standard of care globally. It has limited long-term follow-up data, so we need to be a little critical about this technique. It's only available in specialized centers for now and not suitable for all patients. And of course, the cost and the reimbursement barriers, they still remain. I see that we have only 15 minutes left, so I will go to the last topic that I prepared for you today, and that's about the technological and the tele-lymphology applications. So as the opening ceremony was there was a very important talk, keynote, about this artificial intelligence in lymphology that drew my attention. And I also found afterwards, a very nice narrative review on the techniques, the technology enhanced compression and AI integrated lymphedema care, specifically focused for conservative treatment, so no longer for the surgery. What is the problem that we need to solve? We have some limitations with our traditional treatment with the CDT. I think every one of us knows this. Even with the surgery, there are still some problems. We have limited access to trained therapists. That's something that we saw from the survey, but also poor long-term adherence. The patient response is very variable between the patients. There is a high recurrence without ongoing support, so the patient needs lifelong CDT, and sometimes it's not accessible in low and middle income countries. So up to 67% of the patients have poor adherence, and this is a very high number. So the lymphedema remains undertreated globally. And only 20 to 49% of the breast cancer survivors successfully maintain lymphedema control long-term with CDT alone. So this is less than half of the patients, actually. When we look at this technology, the digital health solutions that we have within this article, in this narrative review, they discuss 3 points. You have telehealth and remote monitoring, you have the mobile apps and the coaching, and you also have virtual reality for exercise. And we have just seen that exercise is a very important modality. So you can see that these domains are really evolving, and this is good to see because it can help us. And there are already some very important initiatives. For example, you can see that there are already wearable smart garments, so compression garments, and advanced pneumatic devices. And you can see them in the slide, in the picture as well. Of course, they have some limitations as well, but so there do exist sensorized sleeves that monitor the fluid in real time, for example. That was something that I wasn't aware of. And there are also pneumatic compression sleeves, or also for the legs, that adapt automatically the pressure within the segment that it is treating. There's also already a DaySpring system. So the DaySpring is the brand that already exists, and it gives 18% improvement in the quality of life. There is also improved, there are techniques for from the Internet of Things enabled adherence monitoring, increasing it by 44% and reducing the cellulitis in resource limited settings. So it's a very dynamic, personalized and feedback driven therapy. I wasn't aware of this, so I wanted to share this with you, that this is something that is in a development state, but that we will get confronted with in the next year. And artificial intelligence is also used for risk and treatment planning. So you have AI models that can predict lymphedema development, machine learning algorithms that can personalize care, and real-time alerts when the fluid threshold in the edematous lymph is exceeded. So with these techniques, we can have earlier intervention, but also better and tailored therapy. So I was very surprised by this. And I wanted to know if it's already in real practice, in real world studies. So I found these 4 success stories with real world implementation. And so you can see that the critical success factors are the data integration, but also cultural adaptations and the scalable infrastructure. But so these are four good examples that I found how these tele and digital solutions can help us in our practice. But of course, the technological readiness level of all these different techniques is not as high. So we still need to have some more time, I think, before we can introduce this into our practice. But I think it's something that we really should follow up on and that can really help us in the future with our practice. So what are the key takeaways for these innovative digital solutions? That our role is expanding. So from hands-on only to the orchestra of integrated digital and hands-on care. That technology might improve the accessibility, and that's something that we discussed at the beginning, that accessibility is a problem in some parts of the world. So we can now reach and support patients remotely in their houses and also across borders. That personalization is supported. So we are already personalizing our care for the patients, but the AI might help us in predict the risk and tailor the interventions for each patient. With these techniques, we can also improve the adherence dramatically. So we have seen some examples that increase the adherence up to even 94%, while we have only 51% of adherence with traditional garments. And equity is achievable. That's also something that is very important for me as a person and as a practitioner, because even in the low resource settings, and we have seen this from our survey as well, they can show excellent outcomes with adaptable and affordable solutions. And with this message, I want to conclude my talk so that we still have a few minutes for questions and answers. So back to you, Helena.
Thank you so much, Nele, for the wonderful presentation. I'm also a certified lymphedema therapy, so I really appreciate all those new updates about risk reduction practice, about surgeries, and this AI and technology. So thank you. And now we have opportunity for some questions. First from Caroline. Thank you, Caroline. Dear Nele, these centers of excellence are very nice. However, the University Medical Center Utrecht no longer wants to be connected to this kind of initiative because of the administrative burden. They have stopped participating in such recognitions. Maybe it's very Dutch perspective, but they currently state that you don't need external recognitions when you deliver high quality of care. So what do you think about that, Nele?
I totally agree. And fortunately, I didn't have to be concerned about the administrative burden. That's something that the secretary is managing for us, but I can imagine that it's really a big burden. Of course, if you deliver high quality care, it's good for the patients and you might not need this labeling. But for me, these kind of initiatives are very important also for a collaborative network. It's important for the patients, but also for us as researchers, academics, but also practitioners to know which centers around the world are doing these kind of businesses. And so then you can connect to each other and you can discuss new innovations, you can collaborate on research and so on. So I'm still very happy that we are part of this initiative. But for the patients, of course, if you have this label or not, maybe it doesn't matter. It's good that we have this listing where you can find these centers. But for me, as a researcher and clinician, it's more that we use it for collaborative networking.
Thank you, Nele. Another question, not related to oncology, but can the collagen matrix be used in primary lymphedema?
I think the primary lymphedema is a very broad pathology. So it might be due to not enough lymph nodes, not enough lymph vessels. The lymph vessels might not be functional, or they might be too big so that the valves do not work. I think it can only work when you need regeneration and lymphangiogenesis. Otherwise, it will not work. I think the indications are very specific. So the criteria for including patients in the trials is also very limited, but very specific. And I think that if the primary lymphedema patients can be within this criteria, it might be helpful, but certainly not for all of them, because it's a very broad pathology, the primary lymphedema.
From Constantine, he was asking, there has been literature that starting devices early and determinantal because they reduce fluid instead of facilitating protein into the bloodstream and out of the interstitial space, thereby facilitating fibrotic tissue and thereby worsening lymphedema. Okay, so thank you for sharing.
Actually, I agree, Helena. I think it's mainly about the pneumatic compression. I think it's also a problem, and there are many contraindications, absolute, but also other ones. And there are also very important side effects of using these things. So if you're not a professional, you do not have to use this. How we use it is first we do the manual lymphatic drainage to get the proteins from the interstitial space inside the lymphatic system, and then have the transportation with the manual lymphatic drainage. And afterwards, you can use the compression just to maintain the volume that you have restored. But if you use the chromatic compression, for example, you push the fluid and indeed not the proteins towards the root of the lymph. And so it stays in the root, so the shoulder or the inguinal area. And we have even seen patients giving the fluid in the inguinal region, taking it into the genital area. So it might be really a problem, especially also with the pressures that you use, that you pump the fluid to another space and actually you're just moving the problem. And the proteins stay behind, and they are like big macromolecules that are hydrophilic. So if the concentration of proteins is higher than the fluid that is there, it attracts more water. And so you will even worsen, in the long run, worsen the lymphedema. So I'm very happy with these comments from our colleague, and I completely agree.
Thank you, Nele. I think it was really good. And I think, with the article about the new updates about risk reduction practice, I think every physiotherapist who treats, patients with lymphedema needs to be updated, because you see in the clinic with the nurses and the patients, there's so many myths about it. And if we want to provide quality care, updated quality care, we need to review all those new articles. So thank you for sharing. There's just another question. Have noticed strenuous exercise worsening lymphedema. I think it's appropriate to do exercise with short bandages on. What are the appropriate exercise?
Yeah, I think in the study of Sandy Hayes, so her real name is Sandra Hayes, if you want to look for the publication. But as you could see in the slides, there were different modes that were described. And so you cannot see it from the table, but if you go into the article, they explain to you which type or mode of and the duration and the length of the intervention is best to use, because it also depends on the stage of the lymphedema, if it's breast cancer related or other cancer related. So it's not a one size fits all program, but they give you some more explanation that might be helpful for you, Constantine.
Okay, and then we have from Fiona, my son was diagnosed with pediatric primary lymphedema this year, but despite sharing the British Physio Network for Global Health and doing a PhD in global health, there is next to no information on how parents manage their children lymphedema. I am now within parent support group where we are really the blind leading the blind. Is there any pediatric resources for lymphedema you can signpost us to? Nele, are you familiar?
Yes, please have a look at the Learn website, because they are also doing a lot of great work for children with lymphedema.
Yeah, Nele, thank you for answering.
Yeah.
I think it's a good point. I know that in England there's strong lymphedema therapist community and doctors who treat that. We would like to thank Nele for a really wonderful presentation. Thank you also, everybody, for coming here early in the morning for some people, maybe for some people later or in the evening. And yeah, I want to say again, thank you also for the IPT-HOPE and the European Region Cancer Group. We all made this happen today, so thank you for everybody, and we'll be in touch. And look out on our websites. We have more webinars coming. In January, we will have a pediatric, but on cancer care for pediatrics, so look for that as well. And thank you.